our cancer detection rates, it's always right around 60%. Well, the national average is somewhere around 45 to 50%. So that means that's an additional 10 to 15% of cancers that are not being missed, that we're able to identify just by the utilization of this emerging technology.
Today, I'm excited to be interviewing our first pathologist on the Prostate Health Podcast. He is a true innovator, and we'll get you up to speed with how he and his team are able to provide the urologist he serves access to state-of-the-art technology to deliver higher quality samples that increase cancer detection rate. We'll also give you a behind-the-scenes look at the journey of a prostate biopsy sample the moment it leaves the clinic, as well as how to make sense of a pathology report for those newly diagnosed with prostate cancer. So stick around. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On the podcast, we'll be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pullman, and welcome to the Prostate Health Podcast. Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. I'm very excited to be partnering with TruCore Pathology for our episode today with Dr. Adam Cole. Here on the Prostate Health Podcast, we've had a variety of guests, including but not limited to urologists, radiologists, radiation oncologists, medical oncologists, and prostate cancer survivors. Dr. Cole will be our very first board-certified pathologist to join us on the show. He completed his residency training in pathology at the University of Arkansas for medical sciences. He also holds a master's degree in health science from Duke University. His clinical focus is genital, urinary, and molecular pathology, and he is currently the Chief Medical Officer for TruCore Pathology, which is a team of board-certified expert pathologists that use the latest state-of-the-art tissue preparation technology to deliver larger, higher quality samples that increase cancer detection. In addition to his 10-plus years of experience as a pathologist, Dr. Cole is also a colonel in the Air Force Reserves and is currently the commander of the 446th AMDS at McCord Air Force Base. Dr. Cole, welcome to the Prostate Health Podcast.
Hey, thanks so much for having me, Dr. Cole.
When determining if a man has prostate cancer or not, we must obtain tissue samples of the prostate to send to the pathologist. The samples are obtained using a biopsy device to obtain small needle core samples. Now, there's definitely a lot that goes on behind the scenes from the time the sample is collected to the time I receive a report back with the biopsy results. I think our listeners would love it if you could walk our listeners through what happens to that tissue the moment it leaves the clinic.
Sure, absolutely. So after you guys do the biopsy, right, you get that little needle gun. It's a tiny little fragment, looks like size-wise, maybe like 1.5 centimeters long, but about as width of some pencil lead. It's very fragile, right? And you put it into a formalin-filled vial, jar, kind of eject that down into that jar as carefully as you can. And then however many biopsies you do, right, whether that's 12 or 12 plus with some lesions that you want to, well, that's 12 plus with some other areas that you also wanted to sample. They get shipped overnight. They land in a lab just like mine. And then we have histotechs. What those histotechs do is they take that tissue out, measure that, take pictures of it. When I'm about to diagnose the case, then I can see those and I can agree on gross measurement, how much tissue was received. And then we go about processing that tissue. So we've got to convert that really fragile, really delicate, tiny piece of tissue into a glass slide so that I, as a pathologist, can then put that under a microscope and take a look at it. So there's several steps in between there as far as you can't just immediately just put that tissue on a slide. It has to be processed. It has to be firmed up, if you will. And during all of those opportunities is a chance for tissue to fragment. And unfortunately, we lose those tiny little pieces of that core during that processing. A lot of emphasis has been placed on tissue retention, if you will. Once that slide is generated, then I, as a pathologist or anyone else, can then look at a microscope and we can start taking a look at it and start identifying if we see any cancer.
Well, thanks for going through that. That's going to be very helpful. And the false negative rate for detecting prostate cancer has been reported as high as 30%. meaning a test result indicating that a person does not have prostate cancer when indeed they actually do have the disease. One of the contributing factors to this high rate historically is sampling error, and urologists are able to now improve upon this with better technology utilizing multiparametric prostate MRI, targeted biopsies to really help detect clinically significant prostate cancer. But another significant reason for false negative results can be, as you mentioned, tissue loss due to poor orientation and fragmentation of the tissue. Could you expand on this, including how does tissue handling actually negatively affect the ability to detect prostate cancer and the solution that TruCore Pathology is utilizing to help prevent this from happening?
Yes, sir. Absolutely. Exactly right. So that is one of my big pushes as well, right? If that is a procedure that you want to make sure that you retain all of the tissue that's been harvested from that patient, obviously. So in lieu of using those formalin-filled vials that we were talking about that you would just kind of eject that tissue into, we use something called a biopsy board. So that biopsy board is a little bigger than a deck of cards, has 6 channels cut into it, and on the bottom of those channels, there's a formalin-filled sponge. So instead of you guys having to eject that tissue and kind of agitate it in order to dislodge the tissue from the needle gun into the vial, you can just lay the gun on the sponge, kind of roll it over, and the tissue comes right off. It gives you immediate feedback as a urologist. Now, the gun can only go in, the biopsy gun can only go in one direction inside this board. So for the first time ever, we've been able to maintain orientation of that tissue. What I mean by that is this the deepest part of the needle, i.e. the deepest part of the prostate that you're biopsying, or is it the area that is most adjacent or next to the capsule, the outside of the prostate? So we maintain orientation through processing, and I can get into that if you'd like on why that is going to become more and more important as we move forward. So now you've got the tissue preserved in that biopsy board. There's a lid that sits on top of it, and it kind of seats that tissue down into the sponge. What that does, so immediately right out of the gate, we have prevented any kind of tissue agitation during transport. So while it's being flown across the country or wherever it's going, those in the vial, it's being shaken. And this, like I say, it's really fragile tissue. Using our methodology, that all prevents. It keeps that core spread out. It keeps it becoming over-soaked with formalin, if you will, but it also helps prevent fragmentation. And while it's in formalin, it's being fixed. It's becoming more firm. The tissue is becoming more firm. Well, because we keep that tissue spread out, it prevents the crinkling of that tissue. If you kind of imagine a piece of bacon being cooked, if you will. Like when you first lay it in, it all lays flat, but as it's being cooked, right, you start getting those undulations in the bacon. Well, that same thing kind of happens with tissue. If it's just left in that jar, it starts kind of crinkling up. When my histotechs have to take that tissue out and they have to stretch it out, those undulations, those natural undulations appear. Well, we don't have that issue anymore because we've, again, focused on keeping that tissue spread from tip to tip. So from the cancer detection rate, right, like out of the gate, just by maximizing tissue preservation so that I, as a pathologist, I'm seeing true tip to tip. We don't lose fragments of tissue doing it this way. So that's one way, like you mentioned. That's a big way that we've tried to combat the false negative rate with prostate cancer biopsies on our end. The other piece is we take that, once we make that slide, we immediately digitize that slide. And so now it's a digital image, no longer has to be looked at under a microscope, can actually be looked at under an iPad with the same magnification. That opens up all kinds of possibilities as far as how can we utilize emerging technologies in order to better identify prostate cancer. One of those right out of the gate is artificial intelligence. And so, not to mention, when it comes time to diagnose prostate cancer, in the old methodology, when I'm using a microscope, I'd have this core and there's gaps in it, just like I say, again, for those natural undulations, and that's why we get deeper levels and stuff. But what I would have to do is like point a dot here with a little ink pen, and then I would say, okay, it goes to here. And then I would take that slide off and I would look at it and I would kind of eyeball, like a pathologist would just kind of eyeball and say, okay, that's about 30% of the core is involved with prostate cancer. Now that we have a digital image and I circle that cancer on the image, well, the computer can calculate an exact tumor volume against core length, right? So that in of itself, I think, is of huge value. You marry that, like I mentioned, with us maintaining proximal and distal, Well, now we're able to actually paint a picture for you, the urologist, as far as within that core, how is that tumor comprised? Is it just little foci of cancer that is discontinuously involving the entire core, or is it more tumor dense? Is it right up against that capsule? Because if it's right up against that capsule, Garrett, like if you're able on a radical prostatectomy to spare nerves in order to preserve continence, to prevent impotence, you're going to try and spare nerves. But if you see that cancer all the way up against that capsule, particularly if it's got involving nerves, you may want to take wider margins there just in order to make sure that you're getting all of that cancer. So I think there's several different avenues, whether the use of artificial intelligence, tissue preservation, and then we're able to combine. So instead of just having one core per slide, we're able to put 6 cores per slide, all while maintaining that orientation. So the last thing I'll say on cancer detection rates for what we're doing and being able to marry these technologies, if I see cancer, I'm going to circle that cancer. I'm going to grade that cancer as far as how bad do I think it is? Do I think it's low grade? Do I think it's an intermediate grade? Do I think it's bad, high grade cancer? But if I don't see any, or if I see areas that are worrisome to me, whether we call these precancerous lesions or areas of atypical looking cells that aren't quite enough to get me over the threshold to call it cancer, but I'm not 100% comfortable with it either, then in those instances, we can put an additional stain on that tissue. So obviously, there's a small increased cost with doing that, and that's why you wouldn't want to order 12 of these stains for every case, if you had 12 cores. But by combining 6 cores per slide, if I order that immunostain, that stain on a single core, well, that immunococktail is going to flow over in all 6 cores, which means I get to look at all 6 cores, but I don't charge the patient or the insurance companies for all 6 cores. By marrying all of those things together, we're able to maintain maximum tissue preservation while increasing cancer detection rates to where ours, so we read, I think, in about 33 different states with 44 different urology groups right now. And honestly, our cancer detection rates doesn't really matter. It's always right around 60%. What does that mean? Well, the national average is somewhere around 45 to 50%. So that means that's an additional 10 to 15% of cancers that are not being missed, that we're able to identify just by the utilization of this emerging technologies.
Well, thanks for going through that. Definitely appreciate some of the innovative solutions that you've come up with. And for the patient, receiving the diagnosis of prostate cancer can be very distressing for men and their loved ones. Where do you go from here? What are your options? One of the key components as a patient navigates his treatment options is understanding the pathology report. For someone diagnosed with prostate cancer, I think it would be very helpful if you could break down the standard report for our audience today.
Yeah. Oh, when somebody can explain it to me, I'd appreciate that as well. I talk to a lot of prostate cancer survivor groups. I get it. We've migrated away from what we've kind of married from Gleason's scoring systems into the new WHO tumor grades. But they're one and the same. And what I mean by that, prostate cancer is unique in lots of ways. One of the ways, it sounds complicated, it's really not, is something called tumor heterogeneity. What that means is that cancer will look different from one end to the other end. And that's kind of unique to prostate cancer. If you see breast cancer, you kind of know it's breast. You see a colon cancer, it all looks the same. Like it just looks like colon cancer. Prostate cancer is not that way. It's not that way in several respects, as well as it doesn't usually form a large mass. Instead, it can often percolate individual glands kind of throughout the prostate, which makes, to your point, sampling those areas even more challenging when you're not actually going after a defined mass. When I'm looking at a core and I identify prostate cancer, the way this works is when prostate cancer first starts out, all that we can really tell is that we've lost a layer of cells. Those layer of cells are called basal cells. Those basal cells are what's keeping everything in check, right? You don't have cancer really if you have basal cells. But the gland itself still looks like a prostate gland. Even though it's cancer, it still looks like a prostate gland. And I can look at that and say, okay, it's just a little small, it's a little too uniform, has a couple other features that help differentiate. But I would say, okay, that is a low-grade cancer. But right next to it may be a cancer that is a little bit further down the line, i.e. it has divided, and while it's dividing, it has lost some of its original genetic material, that was programming it to look like a prostate gland. And so it starts looking a little less and less like a prostate gland. So when I see that, it started to look a little worse. And so in that instance, I would say, okay, what is the most predominant type of cancer I see? Well, the most predominant in this case would be the stuff that looks just like prostate glands. So I'm going to call that a low grade, which is a 3. I recognize that why are we starting at 3? And that's another whole podcast. But let's just say the lowest you can go on a biopsy is a 3. So I would say, okay, that's a 3. But there is a small component of this stuff that is a little further down the line. That I'm going to call a 4 because it's a little worse. So I would say your Gleason grade for this cancer is a 3 plus 4, Gleason grade 7. So the way you read that is the first number is the most predominant. The second number is obviously less than 50%. So that on a 3, 4, 7, right, we would say that is what's termed a favorable intermediate versus if the majority of the cancer was further down the pipe and you've got a lot of 4, but there is some 3, I would say, well, that's a Gleason 7, 4 plus 3, which is obviously an unfavorable intermediate and conveys a lot. The treatment algorithms for you as a urologist obviously differ drastically between whether I put a 3 first or a 4 first. The only other thing I'll say about that, somebody may say, yeah, but I've got a Gleason 8, 4 plus 4. Well, that just means I just saw 4. There always has to be 2 numbers. So if all I see is low grade stuff, then I would say, all right, that's a 3 plus 3, Gleason grade 6. Each of those correspond to a different tumor grade. And so a lot of times in your pathology report, you will see 2. You'll see a grade group 2, and then right next to it, it'll say Gleason 7, 3 plus 4. So there's a direct correlation between those two, if that makes sense.
Well, thanks for going through that. I know it can be somewhat challenging as patients try to make sense of their report and what to make of it. So I appreciate that. Now, we're also increasingly utilizing prostate cancer genomic testing, helping individualize patient care, including tests that help determine who to treat versus active surveillance for those who are newly diagnosed and for those who are already underwent treatment in determining who may benefit from additional treatment. We've covered some of these tests on several episodes, including episode 48 with Dr. Crawford, and episode 67 with Dr. Barbieri. I think one point of frustration for both patients and urologists wanting to use this testing to help in decision-making is that we don't always get a definitive result back. Definitely more often than we like, we get a result back that says, quantity not sufficient to test the panel ordered or QNS. Could you explain what it means to have a quantity not sufficient result and how TruCore is helping in decreasing the QNS rates?
Absolutely. Yes, sir. Yeah, so a QNS can mean several different things. And it really depends a lot on the test that's being ordered as well as far as what requirements are needed. The majority of those tests, 2 out of this section, a lot of those tests require RNA to move forward. The problem, remember when I was talking earlier about when you put that tissue into that formalin-filled vial, particularly if it has to sit over the weekend during transport, it's just sitting there and soaking up this formalin. The problem with that is it's fixing, that's great, but it's also causing cross-linking in that RNA. So even though there may be enough genetic material tumor present for us to get a result, the fact that it has got too much formalin cross-linking in that RNA can actually cause a QNS. It will cause the machine to actually kick it out and say, I can't run it based on all of this trash, this garbage that has infiltrated into the RNA. The other thing it can do, a QNS can be, depending on what the test is looking at, you may need really pure cancer to run this test. What I mean by that is if you may have cancer, but right in the middle is a normal gland, well, they can't just get that cancer. They're going to kind of take, and they'll get some of that normal gland as well. But that normal gland can artificially skew the data so far to the left that they would, even though they've got a result, they would have to cancel it because it's not a true representation of what the tumor itself is programmed to behave like. And then lastly, which is probably the most common, is there's just not enough cancer present on this tiny little fragment of tissue in order to generate a result. So on the genomics, the one piece I did want to kind of throw out there is we can definitely help as pathologists because this is our field of expertise. This is what we're looking at all the time. So we can look at tumor composition. We can look at, like I said, the purity of the cancer, and we can help determine. It doesn't have to be a urologist looking and saying, hey, this number is bigger than this number, so I'm going to order the test on this. When in fact, The more appropriate core may be the one that's more tumor dense or pure. I'll take it one step further. Within the new WHO tumor grades, like I talked about how that relates back to Gleason grade. But the other thing it starts talking about is not every Gleason grade 4 is the same. And what I mean by that is there's 3 or 4 different types of Gleason grade 4 disease, one of which is very easy to identify, and we know it's associated with more aggressive disease behavior, versus the more predominant type of pattern 4 disease as something called poorly formed fusiform glands. In that area, it's really hard for pathologists to agree. Is that true pattern 4 disease, or is that just a funny section of a lower grade cancer and it's just looking strange? So the way we have chosen to kind of be good partners and try and help our urologists, clinicians is, hey, listen, we're going to tell you it's a 347, it's 5% pattern 4 disease, but then we're also going to tell you how confident we are that that's a true pattern 4, as in, hey, by the way, this is something called cribiforming disease. So we know cribiforming is associated with more aggressive disease behavior. So regardless of the Gleason grade, the actual phenotype, how that grade 4 disease looks, the fact it's cribiforming is actually more important to you as the clinician as far as trying to better to determine, should this patient go on active surveillance, or do we need to get more aggressive as far as we need to treat this patient? So in my opinion, that is where, without overutilizing the biomarkers, these are not cheap tests. And so you want to make sure that you're only using them when it's going to affect change on the patient. If the tumor has already declared itself as aggressive, regardless of Gleason grade, maybe that's not an appropriate use of those funds, versus that subset where that poorly formed, where the pathologists struggle to agree on, is this a 336? Is this a 347, small percent pattern 4? Well, in those instances, a pathologist could take a look at that and say, hey, we can add a ton of clinical utility data for our clinicians by just getting one of these biomarkers up front at time of diagnosis. And the reason I say that is because, as you know, Dr. Pullman, the days between when you get a biopsy to when you get a result, those are long days for patients. We've all had family members. I lost my father to bladder cancer, so those are long days between where people are just on pins and needles waiting to find out. What we're trying to do is, okay, they do the biopsy. In a couple of days, they get a pathology report and it says this test is pending. What I really want to have happen is when you're bringing that patient back in, you no longer have to say, hey, listen, unfortunately, we found some cancer, but we have some of these genomic markers we could order to kind of clean up the picture. What do you think? And that's going to tack on another 15, 20 days by the time the order gets put and the pathologist send the slides and all that. Well, what I would much rather have is by the time you bring that patient back for his initial consultation, everything's tied up in a bow. You can say, hey, listen, unfortunately, we found some cancer. The good news is our pathologist ordered the test. We've got this molecular result back, and it looks like we're going to be okay to watch this. That, to me, is a completely different patient experience on that level, where they can, because you know how it goes. As first, as anytime anybody hears they have cancer, is my will, ready? Like, there's no way I'm going to survive this. And everybody starts immediately going down like the worst case scenario road. Where in fact, in prostate cancer, we know most people are going to be okay with prostate cancer. So we just want to go into that fully educated without becoming a burden to the system. And so that's where I think pathologists and urologists can work much more collaboratively as far as identifying a more personalized treatment plan.
Well, I've really enjoyed listening to you, having you on the show today. It's so exciting to hear about the innovative solutions you're utilizing to help improve upon the accuracy and efficiency of prostate cancer diagnosis, as well as with molecular testing. Dr. Cole, final thoughts today for our listeners?
I'm going to leave you with this. It's only going to get better, right? So as we are just dipping our toe into the digital pathology space and all of the avenues that now opens to us. So we know artificial intelligence can help us in the identification of prostate cancer. Well, now we also know that actually it's coming down the pipe and it's quick. It's here. Artificial intelligence is also going to be able to help us identify who's appropriate for active surveillance, who needs treatment. And it'll be instantaneous. It'll be just a click of a button kind of thing. And so in the last few years, we have seen a massive, massive shift in the urology and the prostate cancer space, like you've mentioned, on the genetic side, but also on the digital pathology side and the artificial intelligence side. So bear with us. We're getting better, and we're only going to continue to improve.
Well, thank you so much for taking time to share your wisdom today on the Prostate Health Podcast. Just solid gold. I know I can speak on behalf of all of our listeners that you've delivered significant value today. Thanks again for joining us on the show.
Much, Dr. Paul.
Thank you again for listening to the Prostate Health Podcast. For those of you wanting to dive in even deeper, make sure to check out the Prostate Health Academy, which offers comprehensive and easy to navigate lessons that I've prepared for you. There's also an active private community forum, and I am there every day providing support, insight, and answering questions. To learn more, just go to www.prostatehealthacademy.com and click on Join Now. Well, that's it for today. We will see you at the next episode.